Okay, this is Chris. We're back, and I'm not gonna laugh. Well, maybe I'm gonna laugh a little bit about the ribbons and stuff. Can't help it. It's so funny. So funny. All right, so first thing I want to talk about, big game changer. This was a gentleman by the name of Christopher did a outstanding presentation, a really good presentation. Kudos to you. Christopher Thompson, I believe he's a clinical educator with University of Missouri with their ground transport and their flight team, and I believe that he is both a flight nurse and a paramedic, and then has some critical care experience in the CVICU, so he does have some cardiovascular experience as well. But that aside, just the presentation was really incredible. And so the presentation was not your average STEMI. And STEMI, you guys in healthcare should know, right? ST elevation myocardial infarction, right? This is a cornerstone, this is a keystone, this is a fundamental concept when it comes to emergency medicine, cardiovascular medicine, right? Is it a STEMI? Is it a STEMI activation code STEMI? Big push for STEMI, big push for identifying STEMI. Every paramedic curriculum worth its weight, worth its salt in anything is going to include fairly detailed instruction on identifying STEMI patterns on 12, right? The fundamental 12 lead ECG recognition, right? This is a fundamental part of the paramedic education. Nursing education, not so much. But yeah. So it's kind of important, foundational level providers are learning this, and this is a complete. I think this is a game changer. This concept that he talked about, and it's not necessarily new, but it's just not something that I've really paid a whole lot of attention to, mainly because I feel as a provider, I feel like I had a pretty good understanding of this, and the current paradigm is very comforting and has made sense to me, and so I've just stuck with the current paradigm. I haven't really spent a whole lot of time on this, particularly because I've been so involved in toxicology the last few years. That's what I went to grad school for, so I was really focused on that, and now I have a little more time to focus on some other things in this. So this is really, really, really good stuff, and this is actually changed in one hour. 1 hour, I've completely changed the way that I'm going to approach 12 lead ECG interpretation in the future, and it's fundamentally changed the way that I'm going to teach this to my paramedic students and allied health students. Just fundamentally changed things. This is a paradigm shift as far as I'm concerned, and this actually isn't new. This is come down from other people like Scott Weingart. Actually, he'll be keynote. He's doing the outro keynote in the morning on Saturday. So I get to see him before I have to fly back home. So I probably won't be able to talk to him. Everyone will talk to him, but anyone in emergency or critical care probably knows Scott Weingart, right? He basically started and is the driving force behind MCRIT. If you're not aware of MCRIT, you need to look that up now. You need to Google that. You need to put that in your bookmarks, and you need to go to iTunes or to the Google Play and subscribe to the MCRIT podcast, and then the Tox and the Hound podcast, right? The toxicology podcast, Dan Rosiniak and all. Really good podcast. They're now associated with MCRIT. Just solid material. Anyway, some of that has come from Scott Weingart and company and all. He and some other physicians have done some papers on this. And what is this? So the paradigm, the current paradigm is when we have somebody that presents with signs and symptoms suggesting acute coronary syndrome, right? An acute event that may result in acute ischemia to the heart. This is generally going to be a thrombus, a thrombotic event of some sort, right? And they have chest pain, they have the Levine sign, right? They have signs and symptoms suggesting an acute coronary syndrome. The big paradigm currently is to stratify what kind of acute coronary syndrome is this. Is this a STEMI, an ST elevation myocardial infarction, where you have J point elevation, the ST segments elevate above baseline, right? You have the classic current of injury patterns. Or is this an NSTEMI, a non-ST elevation myocardial infarction slash unstable angina, right? These are the two categories, and if it's STEMI, it's an immediate cath lab activation. If it is an NSTEMI slash USA, generally we do serial 12 leads, we do serial enzymes, we do like a 24-hour, 23-hour observation, or maybe a day obs in a telemetry unit in maybe in 24 to 48 hours. We'll do a diagnostic cath on them and intervene if need be, right? And maybe they'll get some heparin and some adjunctive therapies, right? Okay, so that's the current paradigm. So this new paradigm that is just really relevant and I think makes good sense, not only in a theoretical sense, but in a real fundamentally sound sense from a practical standpoint, from delivering care at the bedside, right? Because that's really more important than anything. And this is something known as OMI, or occlusive myocardial infarction. So it's not STEMI versus NSTEMI USA. Is this an occlusive event or a non-occlusive event, right? So you have near complete or complete occlusion of a coronary vessel, or you don't, right? You have maybe you do have an occlusion, but you have collateral circulation, or it's not a complete occlusion, or it's not an unstable situation, right? And most people, myself included, be like, well, that's basically the same thing as STEMI, NSTEMI, right? STEMI is occlusive, and STEMI is not totally occlusive. No, that's actually not totally reasonable to think that. So this has been termed or coined the OMI, or the occlusive myocardial infarction manifesto, right? And basically it says we're too focused on STEMI versus NSTEMI, right? We need to focus on looking at the history, the patient's history, their signs and symptoms, their history of their past medical history, their history of present illness, their physical exam, and diagnostics, right? 12 lead. It's going to be a big part of that enzymes may play a role as well. We'll talk about that here in a few, all right? So we need to be looking at ischemic versus non-ischemic changes, right? We need to be looking at our classic indicators, the 1 millimeter of ST elevation in 2 or more contiguous leads, greater than 2 millimeters in one lead, right? That's a classic threshold that we use, but there are some other more subtle thresholds, right? What if we have 0.5 millimeters of ST segment elevation in contiguous leads with a patient that has signs and symptoms suggesting acute coronary syndrome? Oh, well, wait a minute, that's not that doesn't mean classical thresholds, but should it, right? When do we activate the cath lab and when do we not? Is it more than just STEMI? Well, let's talk about this. This is really interesting statistics. So STEMI, he's talking about when we do studies. There are a few studies they looked at where we looked at 7-day mortality of STEMI versus NSTEMI patients, right? So 7-day mortality, very similar in both patient groups, okay? That's interesting, right? We would expect that if an NSTEMI, or if a STEMI is so much worse than an NSTEMI, then maybe the mortality would be, right? The acute mortality, 7-day mortality would be higher. We don't see that. If we look at 1 year, right? 1 year mortality. In a STEMI patient, it ranges from 9 to about 15.4%. In the NSTEMI, it's about 11.6 to almost 20% mortality. So I think there's a slightly elevated, I believe a statistically significant elevation in 1 year mortality in NSTEMI patients. What's going on there, right? Are some of these NSTEMI patients more critical than perhaps we used to think? it would appear to be so, right? So we really need to step away from NSTEMI versus STEMI and go, okay, is this an occlusive MI, right? Is this an occlusive event versus a non-occlusive event, right? And one of the points that Mr. Thompson really keyed in on is that thrombi are not static, right? You don't just block your LAD and you have the typical LAD changes, right? V1 through V4 elevated, yeah, right, classic STEMI stuff, right? What can happen? Thrombi can move, right? They can lyse, right? You can have a clot develop in a coronary artery, and through normal lysing mechanisms, right? Normal lysing mechanisms in the body, that clot can lyse. It can break up, and perhaps it can move to other areas, and so this acute coronary syndrome can evolve, right? It can take on, it can be very different, it can change, right? These thrombi, they can move around, they can lyse, it can have a vessel occlude, and then lysis can happen, and then reocclusion can happen in the same vessel or another vessel, right? So this is a highly dynamic situation, and we need to appreciate that. And I just thought, wow, that's really cool. So what we need to do is so STEMI is STEMI, right? If we identify that, ST elevation, myocardial infarction, right? I'm not going to talk about STEMI. We all know what STEMI looks like for the most part. Obviously, that's a clear-cut case that is an occlusive myocardial infarction, but let's look at non-STEMI, right? Let's look at that. About 25% of NSTEMI cases are in fact occlusive myocardial infarction. There is significant occlusion in about 25%, 1 out of 4 NSTEMI patients. NSTEMI/USA, I'll throw unstable angina in there as well, because they're very difficult to differentiate, and often pretty similar. So 1 out of 4 of them are in fact occlusive myocardial infarctions that need intervention. They need primary reperfusion therapies, PCI, right? And these have worse outcomes. These have higher biomarkers of injury, right? These are associated with lower left ventricular ejection fractions. There are more wall motion anomalies in these patients, right? And so things like subtle ST elevation, 0.5 millimeters of elevation, right? Subthreshold ST elevation, right? In some cases can be 70-75% sensitive for an acute myocardial or an occlusive myocardial infarction, OMI, right? So if you have somebody with signs and symptoms of acute ischemia, right, that doesn't seem to be getting better with rest and with nitro and with perhaps a little bit of morphine and oxygen if needed, right, aspirin, and they just have these real subtle ECG findings, that may be somebody who needs to go to the cath lab, even though they don't meet the standard paradigm thresholds, right? So you've got a history of present illness, you've got a physical exam that suggests acute coronary syndrome, and you've got subtle ECG changes, right? Maybe we should take these changes a little more seriously. And then probably one of the most important pictures that he showed, one of the most important charts or graphs, well, picture really, I hand drew it, but it was this thing here. So this really seals the deal for me when he showed this. So we're all familiar with this, right? You have your normal ECG, your J points normal, T waves normal, right? And I think for the most part, most of us understand, right, you have these really early changes which are often not seen because they happen, so early on, and by the time we get, even in EMS, we get to see people, they may be several hours into their OMI. But some of the earliest findings are these really tall, significant T waves, right? These are known as hyperacute T waves. And these can happen within minutes to hours, and then that can progress as you start having injury, right? Significant ischemia causes injury. You get that classic ST segment elevation, J point elevation, right? Within hours of the injury, and then within hours of the injury, as you start having death, necrosis occurring, you'll get pathological Q waves, right? And then you can get some ST inversion with some depression, and sometimes you can get depression as an early finding as well. But right, these classic ischemic findings with these Q waves. Several days into the injury, and then over weeks to months, you have normalization of the J point, the ST segment, with typically the pathological Q waves remain, right? So we're all used to this, but right, we said how dynamic a situation this is, right? So you can have a patient right in here, right? Maybe all they have are hyper Q waves, and then that they have spontaneous lysis of their clot, right? And the ECG changes, right? So they go from maybe these classic indicators of injury, and then you get these weird findings here, right? You get these weird inversion findings, right? Like this is known as a terminal inversion, right? So you have this kind of this inversion of the T wave, this little pseudo plateau kind of morphology occurring here on the T wave, and maybe I'll get in. There's actually more nuance with these, but it kind of starts off with type A, and then it eventually transitions into symmetrical T wave inversion. This tends to occur a little later on, right? And this, right, these interesting these terminal inversion and these symmetrical T wave inversion findings can tend to stick around for quite a while. But right, when we see somebody go from this to this doesn't necessarily mean they're getting better. Or if we see this, right, this is on our initial 12 lead. This doesn't necessarily, we look at this and go, oh, look, that's a T wave inversion here. Oh, that's an NSTEMI, right? I see this in V1 through V4. Okay, I've got some ischemia occurring in the anterior septal leads, right? We may not be as aggressive about intervention when in fact this may have been a STEMI that had some reperfusion occurring, and then later on into their evolution of their acute coronary syndrome, they reocclude, right? And here's the interesting thing. If you see this, right, this tends to be persistent. This tends to stick around for days, weeks. If you see this, right, transition back up into here, that doesn't necessarily mean they're getting better. That could mean they have reocclusion, right? So they have these terminal or symmetrical T wave inversion, and maybe they go back, right? Their J point goes back to normal, or they develop hyperacute T waves. Like, oh, look at that. That's cool. I mean, that ugly thing is changing. No, that's not good, right? When we have highly dynamic findings involving the ST segment, that means that you actually see the segment change. And it doesn't have to be elevation, right? It can be depression. It can be the morphology changing. When things are changing in front of your eyes, when you have high dynamic changes, this is a situation that is dynamic. It's unfolding right in front of your eyes very quickly. That's probably somebody who needs intervention. That's probably somebody who needs PCI, right? Because these are persistent. You shouldn't have these dynamic things. And when these super dynamic things happen, we need to be very concerned. So some other things to think about: subtle ST elevation, right? Hyperacute T waves. We see hyperacute T waves and we rule out hyperkalemia. That's cath lab, right? That's someone who needs to go to the cath lab. Dynamic changes, right? Goes from hyperacute T waves to this T wave depression inversion, and then back to normal sinus rhythm, right? That's not a good situation. That's an unstable situation, right? That's probably somebody who needs to go to the cath lab. Isolated ischemic ST depression. Again, right? This may in fact not be an NSTEMI, right? So maybe we need to rethink our thresholds for cath lab activation, and we need to be thinking about these more subtle findings and these more dynamic findings and perhaps include them in our consideration for cath lab activation. So I think I'm going to cut it off here. There's actually a lot more I want to talk about, and there's some minutia that I can get into, but that's kind of the big picture. I do want to come back and I want to talk about maybe some of the mimics and some of the pitfalls of enzymes and that, but I will just end talking about high-risk patients. So regardless of the ECG findings, there are specific patient categories that tend to be higher risk, right? Refractory angina. Even if you have a normal 12-lead ECG, if somebody has ischemic chest pain, right, or suspected ischemic chest pain, and it is refractory to standard therapy, right? You rest, you give them nitrates, maybe oxygen if needed, right? Aspirin, perhaps judicious use of opioids, and they are refractory to the standard therapies, right? That's an indication for PCI, right? Somebody might need a stent. If they have something known as type 2 myocardial infarction, this is a demand mismatch. Basically, what happens is this is like a high output cardiac ischemia. So somebody who's shocked out, they're in septic shock, for example. Thyrotoxicosis, hypovolemic shock, even, right? They're shocked out. There's a lot of stress being put on the heart, and they start having these ischemic changes, these dynamic ST segment changes. Maybe that's due to the hyperdynamic state, but maybe there's some underlying disease process, right? There's some underlying occlusive process that is now being exacerbated by this increase in cardiovascular demand, right? We might consider intervening in these patients. So just something to think of. Don't necessarily write this off as just purely high output cardiovascular ischemic changes. Okay, cool. So I'm 20 minutes into this. I think this is a really good place to cut off. And perhaps we'll come back and talk about the mimics. There's some really good information about mimics. And interesting enough, the big take-home point about mimics is don't be so quick to write off mimics. Because they're trickier than you might think. And perhaps I have been a little more cavalier about writing what I would consider maybe more clear-cut mimics when in fact it may not be as clear-cut. Now, with that in mind, I want to say that I'm not a cardiovascular expert, right? I'm not an electrophysiologist, right? I'm not a physician that has significant amounts of training in cardiovascular physiology and in dealing with electrophysiology on a day-to-day basis. So your individual mileage on some of this stuff is going to vary, probably, I would say. But take-home point, maybe the paradigm that you have been comfortable with is not as inclusive, and perhaps we are missing patients. There are patients that probably need to go to the cath lab that aren't going to the cath lab, and possibly there are negative outcomes occurring those patients. Certainly the data seems to suggest that, particularly when we look at more longer term outcomes. So just something to think about, right? Just something to think about. NSTEMI may be a lot more ominous than we have been initially led to believe. That's certainly something that I want to impress upon in my clinical practice, and I want to press upon in my students to think about this a little more deeply and be better clinicians. Okay, I hope you guys found this video helpful. This was among one of the most important discussions that I had this entire conference. Really well done. Paradigm shifting is in 1 hour has just completely changed my mind on how I approach this stuff, and hopefully, perhaps, change some of your minds as well. Okay, guys, that's all I got. Thanks for hanging in there.